Welcome to the deep dive. Today, we're really digging into inflammatory and structural heart problems. Definitely a critical and sometimes tricky area for nursing students. We've spent a good bit of time with a fantastic chapter from Lewis's Medical Surgical Nursing, the 12th edition. Our mission here to boil down the absolute must-know info for you. We're talking pathophysiology, risk factors, those key clinical signs, diagnostics, and, really focusing on the nursing management that helps you succeed, both in your studies and, on the floor.
That's exactly right. It's dense stuff, no doubt about it, but we're aiming to break it down step by step. We want to highlight the why behind these conditions, connected directly to what you do as a nurse. We're looking at conditions that mess with cardiac output, right? And that leads to less tissue perfusion, causing things like pain, maybe hyperthermia, definitely reduced ability to function. Getting these concepts down is just foundational.
Okay, so if you're looking for those aha moments, a clearer way through this complex med-surg material, you're in the right place. Let's unpack it. Ready to jump in?
Let's do it.
All right, first up, infective endocarditis, i.e. And this is where things get really quite interesting. We're talking about an infection of the heart's absolute inner lining, the endocardium, and critically, the heart valves. It often carries a pretty poor prognosis, and sadly, we've actually seen cases on the rise largely linked to increased IV drug use.
Right. And it's interesting how we classify it. Sometimes it's by cause, like you mentioned, the IV drug use, i.e., or maybe by the site like prosthetic valve endocarditis, PVE.
Yeah.
We also tend to categorize it as subacute. That's usually in folks with pre-existing valve issues, develops over months, or acute. Acute IE hits hard and fast, often in people with previously healthy valves.
Okay, so walk us through it. How does IE actually start? What's the process?
Well, it typically kicks off when organisms, usually bacteria, manage to get into the bloodstream. Then they find a nice spot to latch onto, often a damaged heart valve or maybe another endothelial surface inside the heart, about half the cases, Staphylococcus aureus. But you also see things like streptococci viridans and the HACEK group of organisms. And these guys are clever. They form these protective biofilms, makes them really tough to treat.
Biofilms, right. That makes sense. So what puts someone more at risk? Who should we be particularly watching out for?
Good question. The main risk factors include having had IE before, definitely IV drug use, having a prosthetic valve, or getting healthcare-associated infections like MRSA, often from things like central lines. Renal dialysis patients are also at higher risk. Your text has a table 40.1, listing cardiac conditions, acquired valve disease, congenital heart disease, even pacemakers. And non-cardiac things, too, like just being in the hospital and getting bacteremia.
Yeah.
They all bump up the risk.
And then the disease itself unfolds in, what, 3 main stages?
Exactly. You've got bacteremia, the bugs in the blood, adhesion, they stick, and then vegetation, they grow. These vegetations, they're the primary lesions, made up of fibrin, white blood cells, platelets, and the microbes themselves. The big problem, they're fragile.
Fragile meaning they can break off.
Precisely. They break off and become emboli. If the vegetation is on the left side of the heart, those emboli can travel to the brain, causing a stroke, or maybe the kidneys, spleen, limbs, leading to infarction. If they're on the right side, they tend to go to the lungs, pulmonary emboli. Plus, the infection can spread locally, damage valves, cause dysrhythmias, heart failure, the whole cascade.
The symptoms, though, they sound like they could be easily missed sometimes. Not always obvious.
They often are nonspecific, yeah. Can involve multiple organ systems. Most patients get a fever, but like we mentioned, in older adults or immunocompromised folks, it might be low grade or even absent. Chills, weakness, malaise, fatigue, anorexia, those are all pretty common too.
But there are some classic physical signs, right? Those telltale clues nurses can look for.
Absolutely. These are key. Look for splinter hemorrhages, those little black streaks under the nail beds. Petechiae, tiny red spots, maybe on the conjunctivae, lips, arms, legs. Then you have Osler's notes. Remember these. They're painful, tender, sort of reddish-purple, pea-sized bumps, usually on fingertips or toes.
Painful. Got it. And Janeway lesions.
Right. Contrast those with Janeway's lesions. These are flat, painless, small red spots. You find them on the fingertips, palms, soles, different presentation. And if you do an eye exam, you might see Roth spots. Those are hemorrhagic spots on the retina. Plus the big one. Most patients develop a new heart murmur, or an existing one gets worse, usually systolic. And heart failure is a really common complication.
Okay, a lot of clues there. How do we actually confirm the diagnosis?
It starts with a really thorough health history. You need to ask about recent procedures, dental work, urologic stuff, any surgery, 4V drug use, history of heart conditions, all crucial. The diagnostic gold standard, usually 3 sets of blood cultures, drawn over about an hour from 3 different spots. That helps identify the specific bug. Other labs might show mild leukocytosis, maybe increased ESR and C-reactive protein, those inflammatory markers, and echocardiography. Absolutely vital, lest you actually see the vegetations.
And I remember reading about the Duke criteria. That sounds important.
Very. They are basically a diagnostic roadmap. You need certain combinations of major and minor criteria to confirm, i.e., things like positive blood cultures, echo evidence of endocardial involvement, like seeing a vegetation, or maybe predisposing factors like IV drug use, plus those vascular signs we talked about, like Janeway lesions.
Okay, so we have a diagnosis. What's the game plan? And importantly, how can nurses help prevent IE in the first place?
Prevention is huge. Prophylactic antibiotics are key for certain high-risk groups. Think people with specific congenital heart defects, prosthetic valves, or a history of IE. Especially before procedures that might introduce bacteria, dental work is a big one. Respiratory tract incisions, surgery on infected skin. Table 40.2 in Lewis's really spells out who needs it and for what procedures.
Good to know for prevention. What about actually treating an active infection?
Identifying that specific organism for the blood cultures is step one. That guides the antibiotic therapy, which is often long. We're talking 4 to 6 weeks, frequently fava, fungal, i.e., or if it involves the prosthetic valve. Those are tougher cases. Often need early valve replacement surgery plus prolonged antibiotics. Surgery is also on the table if valve damage causes heart failure, if there's a high risk of emboli, or if the infection just isn't responding to antibiotics.
And from the nursing side, what are the absolute priorities?
Your assessment is critical. Gathering that subjective data history of, i.e., recent procedures, and the objective data, listening for new murmurs, watching vital signs, spotting those skin signs like Osler's nodes or splinter hemorrhages. Table 40.3 gives a great rundown. Key nursing goals. Maintaining normal cardiac function as much as possible, helping the patient perform ADLs without getting overly fatigued, and making sure they really understand the treatment plan, because it's often long and complex.
Beyond that acute phase, thinking long-term ambulatory care.
Patient education is paramount. You need to teach high-risk patients how to avoid infections, stress, good oral hygiene. Regular dental visits are important. They must tell any HCP about their IE history before invasive procedures. They also need to monitor their temperature at home. A persistent fever could mean the antibiotics aren't working. And they need to know the signs of serious complications, stroke, pulmonary edema, worsening heart failure. Encourage rest, maybe some range of motion exercises, and provide emotional support. It's a scary diagnosis. And always reinforce why they need those prophylactic antibiotics if they fall into that high-risk group.
Okay, shifting gears now. From the inner lining, let's move outward to the pericardium. Pericarditis, inflammation of that sac around the heart. What's happening here?
Right, the pericardium. It's a two-layered sac, normally has just a little bit of lubricating fluid. In acute pericarditis, that sac gets inflamed. Fluid can build up between the layers. That's called a pericardial effusion. Most often, the cause is idiopathic, meaning we don't know, or maybe viral. But Table 40.4 lists a bunch of others. Bacterial infections, acute MI, that can lead to Dressler syndrome, which is pericarditis appearing weeks later. Cancers, autoimmune diseases too.
And the pain, I hear it's quite specific. How does it differ from, say, angina?
It is pretty distinct. Patients usually describe it as progressive, severe, sharp chest pain. The key features. It's typically worse when they take a deep breath or lie flat. And here's a big clue. It's often relieved by sitting up and leaning forward. That posture takes pressure off the inflamed pericardium.
Sitting up, leaning forward. Got it.
Yeah, it can radiate neck, arms, left shoulder, similar to angina sometimes. But a key differentiator is that pericarditis pain often refers to the trapezius muscle ridge, that shoulder upper back area. You don't usually see that with angina. Dyspnea, fever, anxiety often come along with it.
Okay, and the classic physical finding, the sound nurses listen for.
Oh yes, the hallmark. A pericardial friction rub. It's this scratching, grating, high-pitched sound, best heard with your stethoscope at the lower left sternal border, especially with the patient leaning forward. A quick trick to tell it apart from a pleural rub, which sounds similar, but is from the lungs, ask the patient to hold their breath. If the sound persists, it's cardiac. The rub can come and go, though, so you might have to listen a few times.
Now, the complications sound pretty serious, pericardial effusion and cardiac tamponade. How fast can these happen? What are the warning signs?
Pericardial effusion, that fluid buildup, can develop rapidly, maybe after chest trauma, or it can be slow, like with TB pericarditis. If it gets large enough, it can start compressing nearby structures. Pressure on the lungs might cause cough, dyspnea, tachypnea. If it presses on the phrenic nerve, hiccups, laryngeal nerve, hoarseness, and the heart sounds themselves might become distant, muffled.
And then the really critical one, cardiac tamponade.
Yes. Tamponade. This happens as the effusion gets bigger and bigger, squeezing the heart. It's a medical emergency. The patient might seem confused, anxious, restless. Classic signs. Decreased cardiac output, those muffled heart sounds we mentioned. A narrowed pulse pressure, meaning the difference between systolic and diastolic BP gets smaller. You also likely see tachypnea, tachycardia, and jugular venous distension, JVD.
Mm.
And a really critical sign one nurses must recognize is pulsus paradoxus.
Pulsus paradoxus. Can you explain that a bit more?
Sure. It's a significant drop in systolic blood pressure, usually more than 10 millimeter Hg, specifically during inspiration. Normally, BP drops slightly with inspiration, but this is an exaggerated drop. It tells you the heart is being severely compressed and can't fill properly when you breathe in. Your textbook, table 40.5, actually outlines how to measure it precisely with a BP cuff. But for quick recognition, noticing that profound drop associated with breathing is key. It signals a critical situation.
How do diagnostics help pin down pericarditis in these complications?
ECG changes are really common, seen in about 90% of cases. Typically, you see diffuse ST segment elevations across multiple leads. This is different from an MI, where the ST elevation is usually localized to specific areas reflecting the damaged part of the heart. An echocardiogram is crucial. It confirms if there's an effusion and can show signs of tamponade, like the heart chambers collapsing. CT and MRI can give detailed views of the pericardium. A chest X-ray might show an enlarged heart silhouette, sometimes called a water bottle shape, if there's a large effusion. Labs often show leukocytosis, elevated CRP, and ESR, those general inflammation markers.
And treatment. What's the approach?
Well, management, summarized nicely in Table 40.6, really aims at treating the underlying cause if we know it. For the inflammation and pain itself, NSAIDs are usually the first choice. Corticosteroids might come in if it's due to an autoimmune issue, or if NSAIDs aren't cutting it. For tamponade, or if the fluid is pus, purulent pericarditis, you need to drain it. That's done via pericardiocentesis.
Pericardiocentesis.
Yeah.
Inserting a needle.
Exactly. Guided by echocardiography, a needle is inserted into the pericardial space to remove the excess fluid and relieve that pressure on the heart. Sometimes a pericardial window is created surgically, basically cutting a small opening in the pericardium to allow continuous drainage into the chest cavity.
So for nurses managing acute pericarditis, what's our immediate focus?
Pain and anxiety management are top priorities. It's vital to distinguish pericarditis pain from angina. Remember, sharp, precordial, or left trapezius pain, worse with inspiration, better sitting up leaning forward. Position the patient comfortably head of bed elevated, maybe an overbed table to lean on. Give those anti-inflammatories with food or milk to protect the stomach. Advise avoiding alcohol. Explain procedures clearly to reduce anxiety. And crucially, you have to be constantly vigilant for signs of tamponade and ready to assist with pericardiocentesis if needed.
Okay, that makes sense. I remember a check your practice scenario. 58-year-old guy, 3 days post-MI, suddenly develops pericarditis. He's a bit confused, neck veins are prominent, heart rate's 118. What's the immediate nursing action?
Yeah, that's a classic setup for tamponade. The confusion, JVD, tachycardia, those are huge red flags. Your absolute first priority is a rapid assessment, focusing on those signs of tamponade BP, pulse pressure, pulsus paradoxus, if you can assess it quickly, heart sounds. Then notify the HCP immediately. And anticipate needing to prepare for pericardiocentesis. It's a situation that can deteriorate very quickly. And just quickly, on chronic constrictive pericarditis, this is where the pericardium becomes scarred, thickened, rigid. It restricts the heart's ability to fill, mimics heart failure. JVD is often prominent. The main treatment for symptomatic patients is a pericardiectomy, surgical removal of the pericardium. #3 myocarditis.
All right, so we've covered the inner and outer layers. Now let's move to the middle. Myocarditis, inflammation of the heart muscle itself. The myocardium usually causes this.
Myocarditis is often triggered by viruses. Coxsackie A and B are common culprits, but other viruses, bacteria, fungi, even radiation therapy or certain autoimmune disorders can cause it. Essentially, whatever the cause, the agent directly damages the myocytes, the heart muscle cells. This damage then triggers an immune response, which unfortunately can sometimes cause even more destruction and lead to heart dysfunction.
What kind of symptoms would we see? How does it present?
It can vary a lot.
Mm.
Early on, it might just look like a general viral illness, fever, fatigue, body aches, maybe a sore throat. The cardiac symptoms often show up a week or two later. These can include pleuritic chest pain, that sharp pain with breathing, and sometimes even a pericardial friction rub, because pericarditis often happens alongside myocarditis. If it progresses, you start seeing signs of heart failure. Maybe an S3 heart sound, crackles in the lungs, JVD, sometimes syncope or peripheral edema, even angina.
Are there specific tests to diagnose it?
The ECG changes are often nonspecific, but they might show signs if there's associated pericarditis. Labs might show a mild increase in white blood cells, maybe high viral titers if that's the cause, and elevated ESR, CRP, and cardiac biomarkers like troponin indicating muscle damage. But the most definitive diagnostic tool, that's an endomyocardial biopsy. Taking a small sample of the heart muscle itself is most useful in the first 6 weeks of acute illness when the inflammation is most active.
How do we treat myocarditis, and what are the key nursing considerations?
Treatment is largely supportive. The main focus is managing any resulting heart failure symptoms. So you might use ACE inhibitors, beta blockers, diuretic standard HF therapies. But here's a crucial drug alert from Lewis's. Digoxin needs to be used very cautiously. Patients with myocarditis are often hypersensitive to it and prone to toxicity, something nurses really need to watch. Anticoagulation might be needed if the ejection fraction is low to prevent clots forming in the poorly contracting heart. If it's an autoimmune cause, immunosuppressants might be used for severe cases. Oxygen, strict bed rest, maybe even an IABP or VAD for mechanical support. Nursing interventions center on improving cardiac output and managing those HF symptoms. That means decreasing the heart's workload. Think Semi-Fowler's position, carefully balancing activity and rest periods, keeping the environment quiet. You need to monitor the effects of cardiac drugs very carefully, especially digoxin. Managing anxiety is also important, and providing thorough education, particularly if the patient is starting immunosuppressive therapy, about infection risks. ## rheumatic fever, ORF, and rheumatic heart disease, RHD.
Okay, let's move on to rheumatic fever and rheumatic heart disease. This feels like a really important one for students to understand, especially the link to strep throat.
Absolutely. Rheumatic fever, RF, is an acute inflammatory disease. It's a complication that typically shows up 2 to 3 weeks after a group trend, a streptococcal pharyngitis strep throat that wasn't treated properly. And rheumatic heart disease, RHD, that's the long-term consequence. The chronic scarring and deformity of the heart valves that results from RF. It's systemic, though, affects not just the heart, but also skin, joints, even the central nervous system.
So the heart involvement is significant, even if it's systemic. Oh, definitely. About half of RF episodes involve pancarditis inflammation of all 3 layers of the heart: endocardium, myocardium, pericardium. In the endocardium, you get swelling and erosion of the valve leaflets. Little vegetations can form along the edges. Over time, this leads to thickening, fusion of the leaflets, even calcification. This causes the valves to either become stenotic narrowed or regurgitant leaky. The mitral and aortic valves, they're the ones most commonly affected. In the myocardium, you can get these characteristic inflammatory nodules called Aschoff's bodies, and the pericardium can develop fibrosis and adhesions.
And the effects outside the heart? What are those like? Well, you can see subcutaneous nodules, small, hard, painless bumps, usually over bony prominences like elbows or knees. Arthritis or arthralgia is common, especially in large joints, knees, ankles, elbows, wrists. They get swollen, hot, red, tender. Then there's sydenham's chorea. This involves the central nervous system. Causes involuntary, purposeless movements, often of the face and limbs, muscle weakness, maybe speech disturbances. And erythema marginatum is a characteristic skin rash, bright pink, non-itchy, map-like patches, usually on the trunk and limbs. They tend to get more intense with heat.
With such varied symptoms, how is RF actually diagnosed?
Diagnosis isn't based on a single test. It relies on the revised Jones criteria. Basically, you need evidence of a preceding group A strep infection plus a specific combination of clinical findings. It's either 2 major criteria or 1 major criterion plus 2 minor criteria.
Can you give examples of those major criteria?
Sure. The major ones are carditis, that's the most important one, showing signs like new murmurs, heart failure, pericarditis, arthritis, often the most common finding, sydenham's chorea, erythema marginatum, and those subcutaneous nodules. Minor criteria include things like fever, joint pain, monoarthralgia, elevated inflammatory markers like ESR or CRP, and certain ECG changes like a prolonged PR interval. And crucially, you need proof of that recent strep infection, usually an elevated ASO titer in the blood or a positive throat culture.
And the main long-term worry is the heart damage.
Exactly. Chronic rheumatic carditis. That results from the permanent changes to the valve structure, often years after the initial RF episode. Mitral valve is most commonly hit, but aortic and tricuspid can be affected too.
So treatment and nursing care, what's the focus?
Treatment involves, first, antibiotics to eradicate any lingering strep bacteria. Penicillin, often benzathine penicillin G, given intramuscularly, is standard. Then anti-inflammatory agents, salicylates like aspirin, sometimes NSAIDs or corticosteroids to manage the fever, inflammation, and joint pain. From a nursing perspective, the most important thing is primary prevention, making sure strep throat is diagnosed quickly and treated completely with antibiotics. That stops RF from developing in the first place. If a patient does develop RF in the acute phase, nursing care focuses on ensuring they complete the full antibiotic course, promoting rest to decrease the heart's workload, positioning painful joints comfortably, perhaps applying heat, managing fever, and careful assessment. Table 40.9 provides a good overview of the nursing assessment.
And looking ahead, preventing it from happening again.
Right. Secondary prevention is key. Stopping recurrences. Patients who've had rheumatic carditis, especially if they have residual heart disease, valve damage, typically need lifelong prophylactic antibiotics. Even those who had RF without carditis usually need prophylaxis until they're about 20 years old, for at least 5 years, whichever is longer. Patient education is huge here. They need to understand the disease, why the ongoing antibiotics are critical, the importance of good nutrition, hygiene, rest, and knowing the signs and symptoms that mean they need to seek medical care, like fatigue, dizziness, palpitations.
That check your practice scenario about the 28-year-old feeling like a heart cripple really brings home the psychosocial impact, doesn't it?
It absolutely does. He's had carditis, he's facing lifelong prophylaxis, and he's grieving the loss of activities he enjoyed. Your teaching plan has to be empathetic but also realistic. You'd reinforce why that prophylaxis is non-negotiable. Discuss safe activity levels. Maybe competitive skiing is out, but other forms of exercise might be fine. It's about protecting his heart. Connect with support resources, maybe cardiac rehab. Help him understand his condition and find ways to live a full life with it, rather than feeling defined or limited by it. #B, valvular heart disease.
Okay, let's talk about the valves themselves. These incredible structures controlling blood flow. What happens when they malfunction? We hear about stenosis and regurgitation.
Exactly. In stenosis, the valve opening arrows becomes constricted. This obstructs the forward flow of blood. The heart chamber behind the stenotic valve has to work harder to push blood through, creating a pressure difference across the valve. The bigger that difference, the worse the stenosis. Regurgitation, also called insufficiency or incompetence, means the valve doesn't close completely, so blood leaks backward through the valve when it's supposed to be closed. This increases the volume load on the heart chamber receiving the backflow. Causes vary. Congenital defects are more common in younger folks. In older adults, degenerative changes, rheumatic heart disease history, endocarditis, hypertension, these often lead to aortic stenosis or mitral regurgitation.
Let's quickly run through some key valve issues, starting with the mitral valve.
Okay, mitral valve stenosis, MS. Usually the result of rheumatic heart disease. Scarring makes the valve leaflets thick and fused, creating a fish mouth opening. Blood flow from the left atrium to the left ventricle is blocked. This backs up pressure into the left atrium, then the lungs, causing pulmonary hypertension. Risk of atrial fibrillation is high due to the enlarged atrium. The main symptom: exertional dyspnea, shortness of breath with activity. You'll hear a loud first heart sound, S1, and a characteristic low-pitched diastolic murmur. Atrial fibrillation also raises the risk of stroke from emboli. Mitral valve regurgitation, MTR. Here, the mitral valve doesn't close properly during systole, so blood leaks back from the left ventricle into the left atrium. It can be due to problems with the leaflets themselves, primary, or due to issues with the heart muscle affecting valve function, secondary, often after an MI or from chronic RHD. Acute mismotor. That's usually a medical emergency, poorly tolerated, can lead quickly to pulmonary edema and cardiogenic shock. Chronic MMR, though, might be asymptomatic for years. Then symptoms like weakness, fatigue, dyspnea develop. You might hear an S3 sound and a loud holosystolic murmur, meaning it lasts throughout systole, often radiating towards the left axilla. Mitral valve prolapse, MVP. This is where one or both mitral valve leaflets kind of bulge or prolapse back into the left atrium during systole. It's often benign, but complications like significant MR or infective endocarditis can occur. Most people have no symptoms. Some experience palpitations, maybe chest pain, often atypical, occurs in clusters related to stress, usually doesn't respond to nitrates. Dyspnea, syncope can also happen. Beta blockers might help control symptoms like palpitations. Teaching focuses on medication adherence, avoiding stimulants like caffeine, healthy diet, exercise, and reporting worsening symptoms. Cable 40.1 has good teaching points.
Okay, moving to the aortic valve. Stenosis seems common in older adults.
It is. Aortic valve stenosis, AS. This obstructs blood flow from the left ventricle out into the aorta during systole. In older adults, it's often due to calcification and degeneration of the valve. This forces the left ventricle to work much harder, leading to significant left ventricular hypertrophy and increased oxygen demand by the heart muscle. The classic symptom triad for AS is angina, syncope, fainting, and exertional dyspnea. These usually signify significant obstruction and developing left ventricular failure. You hear a characteristic systolic murmur, often described as crescendo decrescendo, gets louder than softer, that radiates up to the carotid arteries in the neck. And here's a huge drug alert. Nitroglycerin must be used very cautiously in patients with AS. It can drastically drop their blood pressure and actually worsen chest pain because it reduces preload too much for the already struggling ventricle. Aortic valve regurgitation, AR. This is backward flow from the aorta back into the left ventricle during diastole because the aortic valve doesn't close tightly. This causes volume overload in the left ventricle.
Acute AR, maybe from trauma or endocarditis, is a life-threatening emergency causes sudden cardiovascular collapse. Chronic AR can be tolerated for years without symptoms. Then patients develop exertional dyspnea, orthopnea, difficulty breathing lying flat, paroxysmal nocturnal dyspnea, waking up suddenly breathless. A classic physical sign you might feel is a water hammer pulse, a very strong, bounding pulse that collapses quickly, also called Corrigan's pulse. Tricuspid and pulmonic valve diseases are much less common, often secondary to other issues like right ventricular dilation.
Okay, Table 40.0 in the text summarizes all these well. What about diagnosing them definitively?
Diagnosis really hinges on a good history and physical exam, especially hearing those specific murmurs. But the cornerstone is echocardiography. Transthoracic echo, transesophageal echo, TEE, Doppler echo. These give detailed pictures of the valve structure, how well they're moving, chamber sizes, ejection fraction. A chest X-ray can show heart size and pulmonary congestion. An ECG looks for rhythm problems, hypertrophy. And cardiac catheterization provides direct pressure measurements across the valves and can visualize the coronary arteries. Table 40.new lists the common diagnostic studies.
Once diagnosed, how are these managed? Is it always surgery?
Not necessarily, at least not initially. Conservative therapy is tried first. The goals are to prevent worsening heart failure, blood clots, thromboembolism, and recurrent infections like RF or IE. This involves things like restricting sodium, using medications to manage HF symptoms, vasodilators, positive inotropes, beta blockers, diuretics. If atrial fibrillation is present, anticoagulants are crucial.
And when conservative therapy isn't enough,
Then you look at more invasive options. Percutaneous transluminal balloon valvuloplasty, PTBV, is one. A balloon-tipped catheter is threaded up to the stenotic valve, and the balloon is inflated to split the fused commissures, the points where the leaflets meet. It's often used for mitral or aortic stenosis, especially in patients who might be too high risk for surgery. It's usually palliative, not a permanent cure, but can provide significant symptom relief. Figure 40.9 shows the Inui balloon technique often used for mitral stenosis.
what about actual surgery, repair versus replacement?
Valve repair is generally preferred over replacement when possible. It usually has lower operative mortality and avoids the need for long-term anticoagulation if successful. Techniques include things like suturing torn leaflets or reconstructing the valve annulus, the ring supporting the valve. That's called annuloplasty. Minimally invasive approaches are also used more now.
And if repair isn't an option, replacement.
Right. If the valve is too damaged, replacement is necessary. Two main types, as shown in figure 40.2. Mechanical valves are made from artificial materials like metal and carbon. They're very durable, last a long time. But the big downside, high risk of thromboembolism. Patients need lifelong anticoagulation therapy, usually with warfarin, Coumadin, and regular INR monitoring. Biologic valves, or tissue valves, are made from animal tissue, porcine, bovine, or human cadaver tissue. They're less durable than mechanical valves, might need replacement sooner, but they have a much lower risk of causing blood clots. So, long-term anticoagulation often isn't needed unless the patient has another reason like atrial fibrillation. The choice between mechanical and biologic really depends on the patient's age, lifestyle, ability to reliably take anticoagulants, and other health conditions.
And those transcatheter approaches are becoming more common too, right? Like TAVR.
Absolutely. Transcatheter aortic valve replacement, TAVR, shown in figure 40.1, has been a game changer, especially for severe symptomatic aortic stenosis in patients considered high risk for open heart surgery. The new valve is delivered via a catheter, often through the femoral artery in the leg. There are also transcatheter options being developed or used for mitral and pulmonic valve issues too.
So, as a nurse caring for patients with valvular disorders, what are the key assessment points and interventions? Table 40.13 looks helpful here.
Definitely. Your assessment needs to be comprehensive. Look at their health history, RF, i.e. congenital issues. Ask about symptoms, fatigue, dyspnea, orthopnea, angina. Then objectively, listen carefully for those abnormal heart sounds murmurs, S3, S4. Check for dysrhythmias like atrial fibrillation. Look for signs of heart failure, edema, JVD, crackles, Watch for signs of embolize stroke symptoms, sudden limb pain.
What are the overall nursing goals?
Key goals include maintaining adequate tissue and organ perfusion, achieving fluid balance, managing potential heart failure, helping the patient achieve an optimal level of activity they can tolerate, and ensuring they really understand their condition and how to manage it. Health promotion is ongoing. Early treatment of strep infections to prevent RF, making sure at-risk patients get prophylactic antibiotics before procedures that cut table 40.2 again.
In ongoing care.
You'll be managing heart failure symptoms if they develop. Helping patients plan activities that balance rest and exertion and strenuous exercise is usually discouraged. Discouraging tobacco use is critical. Education about medications is huge, especially if they end up on anticoagulants after valve replacement. They need to know target INR ranges, usually 2.5 to 3.5 for mechanical valves, bleeding precautions, dietary considerations, and reinforcing the need for prophylactic antibiotics to prevent IE on that new or repaired valve is essential. They should probably wear a medical alert bracelet and carry information about their specific valve.
Let's circle back to that case study, RB, the 50-year-old with a history of IV drug use, alcohol use, now in decompensated HF from valvular disease, severe AMR, AFib, EF of 30%. Unemployed, can't afford meds. What are the priorities?
Yeah, that's a tough, complex, but unfortunately very real scenario. Priority number one is stabilizing his acute decompensated heart failure diuretics, maybe vasodilators, managing oxygenation. Controlling his atrial fibrillation rate is also critical, possibly anticoagulation given the AFib and low EF. Then you have to address the underlying severe mitral regurgitation. He likely needs evaluation for valve surgery, repair, or replacement. But his social situation complicates everything. History of forward drug use increases his risk for IE, especially post-op. Alcohol use impacts adherence and overall health. Being unemployed and unable to afford meds creates huge barriers. So nursing priorities involve not just the immediate medical issues, but also intensive coordination, connecting him with social work for housing, financial aid, medication assistance programs. Addressing the substance use referral to addiction services is crucial for long-term success, especially if surgery is contemplated. Safety is paramount. High risk for falls, emboli, bleeding if anticoagulated, non-adherence. When delegating tasks, an AP can certainly get vitals, weights, may be observed for obvious bleeding. But the nurse retains responsibility for interpreting those vitals, assessing for subtle changes, teaching, and coordinating that complex care plan. ###6X. Cardiomyopathy, CMP.
Okay, last major topic for today. Cardiomyopathy, CMP. This refers to diseases directly affecting the heart muscle itself. Can be primary, meaning the cause is unknown, idiopathic, or secondary, resulting from another disease process.
Right. And CMP is actually a leading indication for heart transplantation. There are three main types we usually talk about: dilated, hypertrophic, and restrictive. Table 40.15 gives a good comparison. Oh, and it's worth briefly mentioning Takotsubo cardiomyopathy, sometimes called broken heart syndrome. It's this transient stress-induced condition that mimics an MI, but coronary arteries are clear, more common in postmenopausal women. But let's focus on the main three.
Let's start with dilated cardiomyopathy, DCM. It's the most common, right? What's happening in the heart?
Yes, DCM is most common. It involves diffuse inflammation and rapid degeneration of the heart muscle fibers. This leads to the ventricles, especially the left ventricle, becoming enlarged, dilated, and floppy. Systolic function, the ability to pump, is impaired. The atria often enlarge too, and blood can pool in the dilated left ventricle, increasing clot risk. A key feature is that the ventricular walls don't thicken, unlike in hypertrophic cardiomyopathy. They get thin and stretched out. Sadly, sudden cardiac death, often from ventricular dysrhythmias, is a major risk. Table 40.14 lists common causes cardiotoxic things like alcohol, cocaine, certain chemo drugs, coronary artery disease, genetic factors, hypertension, viral infections like myocarditis can sometimes lead to it.
How would these patients typically present? What signs and symptoms?
It often develops gradually. Patients might notice decreased exercise capacity first, fatigue, dyspnea, initially with exertion, then maybe even at rest, paroxysmal nocturnal dyspnea, PND, orthopnea. As it worsens, they might develop a dry cough, palpitations, feel bloated, nauseous, lose their appetite. On exam, you might hear an S3 or S4 heart sound. Dysrhythmias are common. Murmurs can develop. You might find pulmonary crackles, peripheral edema, weak pulses, JVD, basically signs of progressive heart failure. And that blood stasis in the ventricle means a higher risk of systemic emboli.
So management sounds like it focuses heavily on treating heart failure.
Exactly. The interventions aim to enhance contractility, decrease preload, decrease afterload, very similar to standard chronic HF management. Table 40.16 outlines the interprofessional care. We use drugs like nitrates, diuretics, ACE inhibitors, beta blockers. Anticoagulants are often needed due to the clot risk. Lifestyle modifications, diet, cardiac rehab are important too. For patients with really severe HF, despite optimal medical therapy, advanced options like a ventricular assist device, VAD, might be considered, either as a bridge to getting a heart transplant or sometimes as destination therapy if transplant isn't an option, or of course heart transplant itself.
What's the critical nursing role here?
Careful observation is key. Watching for any signs of worsening heart failure, increased shortness of breath, weight gain, edema. Monitoring for dysrhythmias, assessing for signs of embolization, evaluating how well they're responding to medications. The goal is really to help the patient maintain the best possible level of function and stay out of the hospital. Including caregivers in the plan is vital. They often need support and education too, including learning CPR and knowing when to call for emergency help.
Okay, let's switch to hypertrophic cardiomyopathy, HCM. This one's different, isn't it? Often associated with sudden death in young athletes.
Yes, HCM is quite different. It's usually a genetic disorder. The hallmark is asymmetric hypertrophy, thickening of the left ventricle, but without the chamber dilating. Often, the septum, the wall between the ventricles, becomes particularly thick. In some cases, this thickened septum can actually obstruct the outflow of blood from the left ventricle during systole. That's called hypertrophic obstructive cardiomyopathy, HOCM. And yes, tragically, HCM is the most common cause of sudden cardiac death in young, otherwise healthy individuals, often athletes. Key features are that massive ventricular hypertrophy, often a hyperdynamic or forceful left ventricular contraction, but impaired relaxation, diastolic dysfunction, and that potential outflow tract obstruction.
What symptoms might someone with HCM have?
Many people with HCM are actually asymptomatic. If they do have symptoms, the most common is exertional dyspnea. Fatigue is also common. Angina can occur, and here's another crucial drug alert. Vasodilators like nitroglycerin can actually worsen angina and symptoms in patients with obstructive HCM because reducing preload and systemic vascular resistance can increase the outflow obstruction. So nitroglycerin is generally avoided or used with extreme caution. Syncope can also happen, often due to decreased cardiac output during exertion or triggered by dysrhythmias. On exam, you might hear an S4 sound and a characteristic systolic murmur.
Given that risk of sudden death, how is HCM managed?
The goals are to improve ventricular filling, which is impaired because the ventricle is stiff, by reducing heart rate and contractility, and to relieve that outflow obstruction if it's present. Beta blockers are often first-line drugs. Calcium channel blockers can also be used. For dysrhythmias, drugs like amiodarone might be used. But importantly, these drugs don't necessarily prevent sudden cardiac death. For patients identified as high risk, an implantable cardioverter defibrillator, ICD, is the main therapy to prevent SCD. There are also procedures. Surgically, a ventriculomyotomy and myectomy involves cutting away some of that thickened septal muscle to relieve the obstruction. A less invasive option is percutaneous transluminal septal myocardial ablation, PTSMA. This involves injecting alcohol into a small coronary artery, supplying the thickened septum, causing a controlled small heart attack in that area, which then shrinks and reduces the obstruction.
And key nursing points for HCM.
Patient education is vital. They need to be advised to avoid strenuous physical activity and dehydration, as both can increase the outflow obstruction. For chest pain, rest and elevating the feet might help improve venous return. And always remember that contraindication or extreme caution with vasodilators like nitroglycerin is critical nursing knowledge for HCM.
Okay, and the last one, restrictive cardiomyopathy, RCM, the least common.
Yes, RCM is the least common of the three major types. The key feature here is stiffness of the ventricular walls. This isn't due to passive thickening like in HCM, but rather due to fibrosis or infiltration of the heart muscle by abnormal substances, like amyloid and amyloidosis, or granulomas and sarcoidosis, or damage from radiation. This stiffness impairs diastolic filling and stretch. The ventricles resist filling properly, leading to high diastolic pressures. Importantly, systolic function, the pumping ability, often remains relatively normal, at least initially.
So what are the symptoms and how is it managed?
Because the heart can't fill properly, it can increase cardiac output effectively, especially with exertion. So patients experience fatigue, exercise intolerance, dyspnea. Signs of heart failure, particularly right-sided failure like peripheral edema, ascites, JVD, are common as blood backs up. Unfortunately, there's no specific treatment that reverses the underlying stiffness in most cases. Management focuses on controlling symptoms, mainly managing heart failure with diuretics and sodium restriction, and treating any dysrhythmias. A heart transplant might be considered in some cases. Nursing care is similar to managing heart failure, promoting rest, avoiding dehydration and strenuous activity. And just to reiterate, for all types of cardiomyopathy, dilated, hypertrophic, restrictive, these patients are generally considered at increased risk for infective endocarditis. So teaching them about the need for prophylactic antibiotics before certain procedures, referencing Table 40.2 again, is important.
Lewis's Table 40.17 provides a really comprehensive patient and caregiver teaching guide for cardiomyopathy, covering medications, diet, activity, symptom monitoring, emergency preparedness, and the importance of caregiver CPR training. Hashtag tag outro.
Wow. Okay, that was definitely a deep dive into inflammatory and structural heart problems. We covered a lot from those tiny vegetations in endocarditis, through the mechanics of leaky or tight valves, to the different ways the heart muscle itself can be affected in cardiomyopathies.
We really tried to walk through the key features of each condition, didn't we? Highlighting those critical nursing assessments and interventions. Hopefully, things like the specific type of chest pain and pericarditis, those classic skin signs in IE, the Jones criteria for rheumatic fever, the options for valve surgery, and the unique challenges of each cardiomyopathy type are clearer now. These aren't just abstract concepts, they're real patient scenarios you'll absolutely encounter. Recognizing those patterns is key.
Yeah, knowing those specific details like the vascular signs of IE, identifying different murmurs, or understanding why nitroglycerin might be dangerous in certain conditions like AS or HOCM, that knowledge really makes a difference in clinical practice, right?
Yeah.
Hopefully you now have a more solid framework for tackling these complex cardiac issues using the nursing process.
So what does this really mean for you, the nursing student or practicing nurse listening? This isn't just about passing exams, though it helps. It's about empowering you to notice subtle changes in your patients, anticipate potential complications, and provide truly effective patient-centered care, understanding the why behind the what's.
We really hope this deep dive has helped clarify things, maybe boosted your confidence in handling this vital area of med-surg nursing. And maybe a final thought to leave you with. Consider how profoundly these conditions impact a person's entire life, not just their physical heart. Think about the complex ethical situations that can arise, like the do not resuscitate discussion mentioned in the chapter, Box 40.1. Your understanding needs to go beyond the clinical tasks to really encompass that holistic care, that patient advocacy piece. Thank you so much for joining us on this deep dive. We appreciate you tuning in and continuing your learning journey with us. Keep up the great work.